Hello, George. I'm just linking the YouTube. So
Great.
hello, George. Good, excellent, great, nice to see you.
Darren, can I try now? I'll
Sure,
share.
please, thanks. If you can, great. That's brilliant.
How's that?
That's great.
It's working?
Yes. Do you want to
And
just
I'm in,
maximize, just to maximize it, just to make sure it's the presentation? Oh, brilliant. Yeah.
does that look okay?
Yeah. It looks it seemed to be a bit zoomed in. I, when you have it in the presentation mode, that it's zooming on part of the slide. So
Say again?
Yeah, Sadi, it's when you're on your presentation mode, it looks to be zoomed in on a portion of the slide. We only see your picture. We're not seeing the rest of the slide for some reason.
Try again. What do you see now?
Just I think you're in normal mode, yeah.
Right?
that looks
And then
better.
how about if when I go to presenter mode, still zoomed?
Yeah,
Zoom
still
in,
zoomed.
yeah. You look
And
good
this,
though.
I appreciate it. And this one?
Yeah.
Zoomed in also. We're getting like,
Maybe 2/3 of the screen or something.
yeah.
Oh, I'll troubleshoot this. I don't want to hold you guys up.
oh, no problem. Dr. Jallo, do you want to try?
Sure, yeah,
You,
I'll try mine.
thank you.
Hopefully you're seeing the slides there,
Yeah.
Darren.
Yeah.
And how's that?
Yep.
It's doing the same thing.
Really, it's interesting. Okay, well, Sadi might not be you, or
Oh, I'm relieved, but I'm wondering, how do we troubleshoot this, Darren?
yeah.
And what's different about Jim's that
Dr.
Jim,
Radka, could
Sadi, are you on a Mac or
I'm on a Mac? Yeah.
I am too. Jim, are you on a Mac or a PC?
Yeah, I'm on Mac, yeah.
Yes, I guess all of us are.
I'm seeing that same thing continue to share.
Yeah. I mean, Jim, your slides look great. I mean,
Yeah.
I think if it doesn't project, then you probably have to do it without the presentation mode. We can still see the slides
yeah.
quite well. So,
I'll just maximize my non-presentation mode. How's that? Shall I try again?
yes, please, thanks.
Okay, I just stopped.
Okay.
I mean, that's, yeah.
How's that?
That's good.
All right, then you'll have a preview of everything coming up. How's that?
Okay.
Yeah, that wouldn't be the end of the world. Yeah.
I hope. Let me just try the introduction that I have here. Just a second. Whether my Zoom is just adds so many things that it's okay. Let's see whether is that coming out right for you.
Yeah.
Yes.
Okay, brilliant. So I'll just send an email just to all the delegates just again. So if you just bear with me for just a couple of minutes. Mm. It's amazing how Zoom keeps changing all the time, and it does make it okay. Can you see me clear there?
Yep.
Brilliant. So I think it's time so we can start the meeting. Thank you very much for faculty and all the participants who are attending this pediatric epilepsy surgery webinar symposium. The interest has been great, and anyone who misses, I will send them the recording. And we have got three distinguished speakers to give us, to teach us on pediatric epilepsy surgery on three very interesting topics. And the first speaker is Dr. James T. Rutka. All of you know him. He doesn't need introduction, but it's always good to introduce, because the things that you don't know, Dr. Rutka is also quite impressive. Dr. Rutka, as you know, is an icon of neurosurgery. He has excelled in every facet of neurosurgery as a surgeon, as a researcher, as an academic, as a mentor, as a as a president of the AANS, and the editor-in-chief of the Journal of Neurosurgery. So it's a remarkable that he has attained the peak of every aspect of neurosurgery. As one of his fellows, who was a senior consultant to me, said, there's not likely to be another Dr. Ratka in future, and I fully agree. So he's like a aircraft carrier. He has got every tool. Dr. Ratka is from Toronto, born there. He did his undergraduate studies in Princeton, and he there played the American football there. And there's a video of that on the YouTube that one of his fellows, Dr. Lowe, showed me. I was very impressed. So it's not neurosurgery. He's also a all-American hero, but a Canadian one, having played for Princeton, and it's a really remarkable video. It's worth watching. Then he went to do medical school at the Queen's University Medical School in Toronto. And then he did his residency in Toronto. After that, he went and did a PhD in San Francisco. And also he did do a fellowship in Japan with Dr. Sujita. And after that, he did another research fellow, that was a clinical fellowship with Dr. Sujita. Then he did another research fellowship at Juntendo University in Tokyo. It's one of the prestigious universities in Japan, from 1863, the first Western medical university. After that, he came back to Toronto, and the rest is history, as you know. So one of the things about Dr. Radka is that I actually calculated all the years that I have known these three faculty members, and it came up to 75 years. And I have known Dr. Radka since 2005. He was at the time, I think, the president of the AANS, and I wrote to him. This was before I started neurosurgery residency. I was doing a neurosurgery quiz, and I asked him whether I can use Dr. Hoffman's slides that he had on their website, and he took time to write to say that I could use it. And then I went and spent 10 days with him, which was a very important influence on me. So thank you, Dr. Radka. We are greatly looking forward to your lecture, sir. Thank you.
Yeah, well, thank you very much, Naren. It's great to see you, and I'm delighted to share the podium today with my good friends and colleagues, Sadi and George. And I'll just be speaking today about hemispherectomy, a topic that over the years I have come to enjoy from many perspectives in terms of the surgery and all sorts of aspects of this particular condition. But first, Naren, I want to thank you for all that you've done over the years for neurosurgical education worldwide, because with your webinars, especially at challenging times in the world, like during the pandemic and before that time, you were among the first to utilize electronic and digital communications with the neurosurgery world. And for that, we are truly grateful to you. And I understand now you're in Singapore, so hopefully I'll get a chance in the future to visit with you in the country in which you live at the moment. So I understand there are something like 90 countries online today. So welcome everybody, and we'll proceed with talking a little bit about hemispherectomy. The history is very interesting. So Dandy performed hemispherectomy in patients who had malignant gliomas, thinking that before they were to transfer to the contralateral side, if you removed the diseased hemisphere, then you could make those patients free of tumor. Of course, that proved not to be true. Mackenzie, who's a University of Toronto, he's the first chair of neurosurgery in Toronto. He performed the first hemispherectomy for epilepsy, and that patient did extremely well after the hemispherectomy. Rasmussen in 1970 devised functional hemispherectomy. Villemure described the peri-insular hemispherotomy. That's a technique that many of us have used over the years, and I use a modification of that procedure. Carson described hemidecortication. We've done that previously at the University of Toronto. Delalande in 2007 describes vertical parasagittal hemispherotomy. And then most recently in advance has been Chandra's description of robotic hemispherotomy, which I'll describe at the end of this presentation. So there's Harvey Cushing, the so-called grandfather of neurosurgery, and standing next to him is K.G. Mackenzie, the gentleman who performed the first hemispherectomy in Toronto at the University of Toronto, who trained with Cushing in the 1920s before coming back to Toronto and starting the first program of neurosurgery in Canada at the University of Toronto in 1924. So we just 1924. So we just celebrated, it turns out, our 100th anniversary for the University of Toronto in neurosurgery. These are the main conditions for which hemispherectomy is applied. So Rasmussen, Sturge-Weber, perimiddle cerebral artery infarction, hemimegalencephaly, cortical dysplasia, and polymicrogyra. So if you remember this list, then what you'll do is you'll be able to score 90% of all cases in which hemispherotomy is required. There's some other examples of diseases, and I'll talk about those in a moment. But for those conditions I mentioned, these are some of the imaging features. So hemimegalencephaly, very disturbed hemisphere, Sturge-Weber, the typical tram track appearance with the affectation of the hemisphere, and you can see the atrophy that takes place. Rasmussen encephalitis, where you also have atrophy without the enhancement, and here whole hemispheric cortical dysplasia. And in the days when anatomic hemispherectomies were performed, this would be an example of what a hemisphere would look like after an anatomic hemispherectomy. There are some less common indications for hemispherectomy, and I'm listing them here, and I've operated on children who've had all of these syndromes and also neurosurgical conditions. And so these are more rare, but on occasion, the repertoire of conditions for which hemispherectomy is indicated expands, and these are some of those situations. So what do you need to know? If you're doing hemispherectomy, you should study in advance on your MRI scan the ventricular size, the Sylvian fissure, where is the circular sulcus, location of certain landmarks, thickness of the corpus callosum, understand the surface anatomy. If there is parenchymal atrophy, that's a favorable situation. And if there's abnormal vasculature, you should have your eyes open for these alterations because they will affect the way in which a hemispherectomy is performed. What's the optimal timing of surgery? Usually this is best in children under age 2. After the 6th to 8th year, of course, the dominant hemisphere is developing. And so if you have a requirement to do hemispherectomy on the dominant hemisphere side after age 6 or so, what happens to language is still unclear. So this supports earlier surgery in pretty much all cases. And there's higher success the shorter the time is between the seizure onset and surgery. And early seizure control allows for optimized psychosocial development. And I've done hemispherectomy as young as 2 months of age. Over the course of time, we've gone from maximal neurosurgical procedures and removal of tissue to more minimal forms of disconnections and tissue removal. So from anatomic hemispherectomy all the way down to central vertical hemispherotomy, maximally invasive down to minimally invasive over the course of the last 50 years or so. We did a comparison of 2 techniques, so periinsular hemispherotomy versus hemidecortication, and the hemispherotomy is typically better tolerated, especially in the young child, less requirements for blood transfusion, less incidence of CSF shunting. And for hemidecortication, there was definitely a higher incidence of shunting and challenges at times knowing how much of the neocortex to remove. An example of periinsular hemispherotomy, and here's an example of hemidecortication at the time of completion of surgery. And we published this in Neurosurgery a while back, comparison of our 2 techniques. But since that time, we've moved almost exclusively to periinsular hemispherotomy, although we're moving towards doing the vertical hemispherotomy. But it's a radical hemispheric tractotomy. And so there are various steps involved in hemispherotomy: a suprainsular window, infrainsular window, temporal lobectomy, corona radiata transection, corpus callosotomy, frontal basal disconnection, and insular resection. And pretty much you proceed in that order. It can be plus or minus depending on the anatomy you're facing, but generally speaking, these are the steps involved in hemispherotomy. So for the insular windows, you'll recall the suprainsular window and the infrainsular window. Here's the insular cortex, so periinsular hemispherotomy. And a very important landmark is the corpus callosum, and located here, which you'll be finding. And you do a corticectomy of these windows, of the supra and insular windows. So removing the temporal lobe, you don't have to do a temporal lobectomy for hemispherectomy. I have done it, and in fact, Vilmur, who described the technique at first, said temporal lobectomy was not necessary as long as you disconnected the mesial structures, especially the fornix, and you do a hippocampectomy. But he faced some challenges with venous congestion of the temporal lobe and had to go back at times to take out the temporal lobe because of the venous congestion. So by and large now several groups, and mine included, we do temporal lobectomy, including mesial structures, and that comprises the infra-insular window. And here's some of the anatomy that you can see of the temporal lobe, and then the trigone of the ventricle and the choroid plexus in the ventricular system. The corona radiata transection, this is really going across the corticospinal tract. So once you're in the lateral ventricle, the corona radiata, can be transected from the temporal horn to the trigone, and then anterior to the extent of the frontal horn. So you're in the trigone here, you go temporal horn to the trigone, which is here, and then forward towards the frontal horn, and you disconnect and you undercut the corona radiata as you do this procedure. Then there's the callosotomy. This is after the temporal lobe and the mesial structures. And I have a brief video here, but this is probably where this blue dot is likely the location in which I find the pericallosal vessels from within the ventricle. So it's about 1 centimeter above the foramen of Monro here, up in this direction, and then you're aiming superiorly so as to come across the corpus callosum. The patient's in a lateral position, and this is the video that shows this corpus callosotomy as you're within the ventricle. So unlike a callosotomy that is done from above, interhemispheric, this is from within the ventricle. So it's kind of curious that now you're seeing the pericallosal vessels from within the opened ventricle. So we're about 1 centimeter above the foramen of Monro, which was there, and now we're finding the pericallosal vessels from within the ventricle. You can see that. I'm just speeding the video along, and we're going anteriorly towards the genu of the corpus callosum, towards the rostrum, and now we're going posteriorly, and you can see the interhemispheric space here as we go as far back as we can on the opening of the callosotomy, doing the body, the genu, the rostrum, towards the splenium. And then there'll be other steps involved. There's a posterior disconnection step, and here it is in the yellow on this anatomical sagittal image. So we've left off with our callosotomy in the previous slide, previous video about here, and now we'll pick up with the disconnection of the hemisphere by following the falx down to the tentorium like this and following it out into the temporal lobe. Here's a video of the posterior disconnection, and so what you're seeing, this is the free edge of the tentorium here. The falx is up here, so falx becoming the tentorium, and then we're going to follow this all the way through until we get into the temporal horn, and we've disconnected essentially the posterior structures by following the tentorial edge all the way out. And you come across the calcar avus. You're just behind the tail of the hippocampus and the fornix at this stage. And already you've done a very extensive hippocampectomy, so everything should be disconnected posteriorly with this hemispherectomy. And then finally, there's the removal of the insula, and there's also frontal basal, which I'll get to, but the insular resection you can do it one of two ways. One is going in between the penetrating vessels, the arterioles of the insula, which is a very good technique and sometimes the only technique to use, or sometimes you can do this on block elevation technique. And I'll show this in the context of a child who has Sturge-Weber, and you'll see the discoloration of the insular cortex here, where my arrow is pointing, and we're lifting up the insular cortex, having undercut it. Now here's the ventricle that we're in, and we've undercut the entire insular cortex, lifting it up. Remember, the insular cortex is only about 3 millimeters thick compared to the regular cortex, and this is one way to do on-block resection of the insula. But as I said, sometimes you have to go in between the penetrating arteries of the insula and just shave down the insular cortex so as to achieve an insular resection. Seizure outcomes after surgery for anatomical hemispherectomy, about 80 to 90% good seizure control. It's a little bit better for peri-insular hemispherotomy, and better outcomes are observed in the context of Sturge-Weber, Rasmussen, perimiddle cerebral artery infarction syndrome. Some complications arise after hemispherectomy, including with anatomical, slightly higher mortality rates, CSF leak, wound infections, and the like. Sinus thrombosis is also quite possible to happen with anatomical hemispherectomy. For periinsular, lower mortality in general, less blood loss, less incidence of CSF shunting, and no, this condition, superficial siderosis, is almost never seen in periinsular hemispherotomy, and probably its incidence is quite low even in anatomical, but it has been reported. So in the last 2 years, you can just take a note of this article we published over 35 years, and there's no question as you do this procedure over many decades, your experience improves, and you also get better outcomes given the complexity of the surgery. Now I'm sharing the load of the hemispherectomies at Sick Kids with Dr. George Ibrahim, who's outstanding epilepsy and functional neurosurgeon. You can see that our hemispherectomy numbers have increased over time, and the age at which we've been doing it slightly increasing over time. But again, the take-home message is the earlier you do hemispherectomy, the better. The indications for hemispherectomy prior to 2013 were these: so Hemi-Meg, Rasmussen, cortical dysplasia, Sturge-Weber, and stroke. But after 2013, we had a higher incidence of patients with the middle cerebral artery infarction syndrome, polymicrogyria, and Hemi-Meg, and so on. So a slight difference over these decades in the etiology for the hemispherectomy. In terms of seizure outcome, seizure recurrence predicting was better as you had more experience, and then certainly seizure freedom became better over time. The results are probably not here statistically significant, but over time, just generally speaking, as you do this particular procedure over the course of many, many years, your results get better. And here, proportion of patients achieving seizure freedom just gradually increasing short-term and long-term, and the number of patients with complications decreasing over time, just demonstrating an experience that is garnered over the course of time with a complex procedure like this. These are some of the complications that will arise following hemispherectomy in patients with the periinsular hemispherotomy technique. So incidence of hydrocephalus, less than 10%, probably on the order of 5%, and then some of the others. So very well tolerated, and very few, catastrophic side effects from this procedure. So case one, just a couple of illustrations. A 2.5 months. So 2.5 months, female with seizures starting first week of life. MRI demonstrated left occipital cortical dysplasia that you can see over here. Just couldn't stop the seizures. Infantile spasms developed, and this was kind of an emergency situation where the neurology team asked us to do surgery at this very young age, pointing out there where the abnormality is on the MRI scan. It's typically quite extensive, involving multiple lobes. Surgery was done in about 5 hours, spent about a week in hospital afterwards. The hemiparesis was slightly worsened, but recovered to baseline after the surgery. Angle 1 now, many years after surgery. There's on the initial post-op CT, the frontal cut, the occipital disconnection cut that you can see. The callosotomy is also visualized there. There's the callosotomy, there's the frontal disconnection. Here's the partial removal of the temporal lobe, and the mesial structures have been removed. And this child has done extraordinarily well, as mentioned. So we've learned over the years that you can use functional mapping, but more importantly, for this condition, you can do this with infants as young as 2 months of age. But there are some technical considerations and complications. So Sadi and also George know that operating on a 2-month-old and a 1-month-old is challenging. And if you're doing an extensive procedure like this, the post-operative scans look like this. So they're quite obvious that the brain is very soft, and you have to really know your anatomy and your landmarks in order to do this successfully. But this was a case of hemimegalencephaly in a very young infant, and we did the hemispherectomy, and this is what it looked like in the long term. You can see the disconnection front and back. The callosotomy has been performed, and this child has become seizure-free. And so you can rescue these children, make them seizure-free, despite the fact that many of them are in a state of catastrophe with their seizures at a very young age. So you can rescue those children. So here's another one, case two, 18-month-old boy with transposition great arteries, heart surgery at a very young age, had a left middle cerebral artery infarct, intractable seizure since age 8 months, using left side, some right-sided movement, right arm is flexed at the elbow, standing with assistance and vocalizing. So 18 months of age at initial surgery. There's the stroke that you can see. And here's before and after the surgery, having done a periinsular hemispherotomy and opening essentially along the Sylvian fissure. And this operation was about 3.5 hours, 1 week stay in hospital, no change in neurological status, seizure-free at 5 years. And here's the immediate post-op CT scan looking like this, with frontal and posterior disconnections having been performed. Diffusion tractography, so DTI is a technique for tracing white matter pathways, and we've used DTI just to examine whether there are any residual connections in any of the work that we've done. Here's where, after a hemispherotomy, we found a small residual bundle going across the corpus callosum by functional MRI. Here you can see it in the basal part of the rostrum of the corpus callosum, which is often where you might have a persistent connection. So we've used DTI to help us identify this. And if you do surgery in these cases, it's like a 15, 20-minute operation with navigation to find where there's small connection might be left. And on this video, to disconnect this very small connection. And then these children can be rendered seizure-free again. And this is worth doing even 5 or 10 years after the initial hemispherotomy if they have a seizure recurrence. We've also used MEG for hemispherectomy, and here you're seeing the advantage of MEG. If you have a unilateral cluster where the hemisphere is abnormal, that predicts better for seizure outcome than if you have bilateral clustering, which is shown here, where the outcomes are not quite so good. And of course, this is important for those centers that have MEG. It's still a very expensive technology, but we've published our results with MEG in hemispherectomy. I just want to show you some outcomes in children who have had hemispherotomy. And this is a child 1 week after hemispherotomy, getting up and walking after a functional hemispherotomy, as shown here, climbing stairs 1 week after surgery, which is, I think, the fastest return to function that we have seen, obviously with the hemiparesis, but proceeding very well 1 week after surgery. And here, many years later, skiing. This is the same child after hemispherotomy, skiing here in Canada, of course, a great sport. And here, scuba diving, here again on water skis, and then here, snowboarding. So our waterboarding, you can see the hemiparesis on the left arm, but amazing. This is a child with Rasmussen encephalitis who had a fantastic outcome. So what have I learned after 35 years? These are some, I would say, pearls that I can pass on to you. Begin with temporal and frontal opercular resections. Find the pericallosals within the ventricle early. Sharply divide the ependymal veins. As you're in the ventricle and you're cutting across the pericallosal vessels, there are all these ependymal veins. You want to make sure you cut those sharply after you coagulate them. The falx is your friend. You're following it to the free edge of the tentorium so as to do the posterior disconnection, preserve all branches of the posterior cerebral artery over the tentorium. And there are different strategies, as mentioned, for resecting the insular cortex, but be aware of venous drainage anomalies in Sturge-Weber. And here's an example in Sturge-Weber. The entire ventricular system, lateral or even central, can be filled with these huge venous channels, and that may be a contraindication for doing periinsular hemispherotomy in the ventricle if you've got all these venous anomalies within the ventricular system. There's subtotal hemispherectomy now, where you preserve this. Here's the central sulcus. You do a frontal and posterior disconnection, preserving the central sulcus. And I've done this on a few occasions. It's technically a demanding procedure, but it preserves function. And I don't think the seizure outcome yet has proven to be as durable as in hemispherectomy for sure. So we need more data on this. And then this is a vertical parasagittal hemispherectomy. You can see the cuts here. Case shared with me by Thomas Czech in Vienna, different technique. And then finally, the robotic thermocoagulative hemispherotomy by Sarit Chandra, where he has disconnected the entire hemisphere using radiofrequency ablation. Great technique, likely to be advanced over time. And think about minimally invasive approaches. This is it. So stay tuned to some more advances for thermocoagulative hemispherotomy. For those interested, here's some further reading that you can do. Some of these I've already alluded to in my presentation today, but this is an experience garnered now over 35 years. I was very happy to share this with you, and I'd be very happy to take any questions that you may have. So thank you for your attention, and thank you, Naren, for the invitation. I'll stop sharing and be happy to answer any questions.
Thank you very much, Dr. Radka, for this excellent lecture, which I understood, even though I'm not an epilepsy surgeon, of a very complex operation. I just want to first of all ask our faculty whether they have any comments or questions. Dr. Jallo, do you have any comments or questions for Dr. Radka? Thank you.
Naren, thank you. Jim, that was an excellent presentation. I think, if this is a demanding operation, as we all know, and you've simplified it so well and so eloquently for the participants. I think it's critical that if you're going to pursue this path of doing a hemispherectomy in a child, that you understand the anatomy and follow the steps that you have outlined. Because as you said, you can get lost in there, and an incomplete disconnection will result in the return of the seizure. So I think it was just wonderfully said. So thank you for sharing your 35 years of experience with this technique. Jim, one question. The Baltimore group at Hopkins, we published a paper using endovascular disconnections.
Yeah.
And I've got mixed feelings about it. So I'm wondering your thoughts. You shared Chandra's paper about the thermal ablation for hemispherotomy. The other technique that we were doing is the endovascular occlusion of the vessels in a staged approach, more of a minimally invasive. I mean, do you think that's the future, or we're still going to be doing open surgery for these?
Yeah, thanks very much, George. Yeah, just to comment on your first point, and yeah, if you're going to do this procedure to everybody online, practice if you have the option to go to either an anatomy lab to do the steps step by step that will prepare you for this. Go somewhere where they're doing these cases so you can actually see them firsthand and look at the steps that are involved. This session is going to be recorded, so you can look at the steps that I've already outlined for you. But you need to practice. And there's also now a simulated hemispherotomy model that we published on from sick kids. So there are many teaching tools to help you with this strategy. So learn those. Try to get a senior person helping you with your very first case if you're just starting your practice. And that way you'll be able to build your experience and help your patients best as possible. And if you have recurrence, because of incomplete disconnection, that's not the end of the world. You can always go back, but you really have to study where the incomplete disconnection was made, and then go back to that focal site. And these patients can be rendered seizure-free over time. Now, as far as the endovascular, George, that's a great question. And we did our first about a year ago. We hadn't done it before, but based on the paper, from Hopkins, we decided to do one, and it worked well in a very young infant, 3 months of age, who had not only tuberous sclerosis, affecting both hemispheres, but had hemimegalencephaly on one hemisphere. So very curious, and we thought, you know what? In this case, surgery is pretty morbid, and the outcome for this child is unknown at age 1 or 2 months. So we did on the affected hemisphere, the hemimeg side, we did an endovascular, and it worked great. We had to stage it over like a month and a half, doing one like the anterior cerebral, then middle cerebral, then posterior cerebral artery blockades. But after that, this child did remarkably well, and seizure is not while seizure-free, but has markedly improved in seizure control. So I think it's a back pocket strategy that you can use, and it may become even more interesting over the course of time. It requires a lot of resourcing, and you can't do it all at once. Typically, you usually stage it, but something to consider, George. So thanks for bringing that up.
Thank you, Dr. Jallo. Dr. Sari Gatan, your comments and questions for Dr. Radka. Thank
Yes,
you.
excellent lecture and great comments, guys. I think that we've always got to search for a less invasive way of getting it done. I think that a critical point that you made, Jim, that I want the audience to really take to heart is the sometimes very rapid, but ultimately very satisfying recovery that these children make, which is critical to know and take to heart with the families. This represents the most invasive conceptual intervention one can take in neurosurgery, really, disconnecting half a hemisphere, removing half a hemisphere historically. And while it may look less invasive to do a periinsular functional hemispherotomy, it still represents a disconnection of half of that child's brain. And yet they do better when you do that. And that is critical to take home to the families and your referring neurologist, because that level of invasiveness is often lost on those who are thinking about doing it. It's very important to remember these kids make a great recovery in the vast majority of these cases.
Yeah, thanks, Adi. Some of my best patients in my entire practice in 35 years are the kids on whom I've operated with hemispherectomy. They have a life. I mean, they had no life going into, coming into the world, but seriously, many are fabulously well, obviously with deficit, but without seizures, like seizure-free, off medication, normal schools. The child I showed you who was skiing is off, graduated from university, is now fully employed. I mean, amazing outcomes. Are they all like that? No, I'm can't say, because some children are very devastated going into the hemispherectomy with global developmental delay, etc. But you can very much impact on their seizure control, which offers them, I think parents would all agree, a better quality of life.
Thank you. Dr. Radka, thank you very much, Dr. Gatan. Dr. Radka, there are a couple of questions that I will read out. First of all, from Dr. Shoaib, I think you touched on it that this lecture is recorded, so you can go through the step-by-step of how you do your peri-insular hemispherectomy. But the question is that I think the broader question is that you have got a lot of skull-based courses, a lot of spine courses. I don't come across so many epilepsy surgery courses, but I do come across many epilepsy surgeons who do struggle with hemispherectomy. And also, could you elaborate on the virtual simulation or the simulation system that you and your colleagues developed? Thank you, sir.
Yeah, thanks. So we teach an epilepsy course. I think Cleveland Clinic has an epilepsy course where procedures like hemispherectomy are instructed. So those of you online, if you're wanting to get into this realm of surgery, you can write to me and I can let you know when some of our next courses are being given to our residents, but it's at least once or twice a year. And these are great, these epilepsy courses, not only hemispherectomy, but open callosotomy, lobectomies, deep brain stimulation, electrode insertion. We're doing everything to teach this. And same thing with Cleveland Clinic and multiple other courses that are available. That simulated model, Naren, is online, Journal of Neurosurgery. And Grace Tiango was a PhD fellow working in Dr. Drake's in my laboratory, and she developed a model. It's a simulated model for hemispherotomy. You make a model and you follow the steps, and there are key landmarks found as you complete each step within the simulated model. So I would refer the readers just do a search under Rutka and simulation and hemispherotomy, and you'll find the paper.
That's brilliant. Thank you so much. That's very good to know. There's a question from Dr. Dirk van Roost. His question is the anterior commissure generally interrupted during peri-insular hemispherectomy?
Yeah, thanks. Great question. The answer is
Hemispherectomy.
yeah, not routinely. As you know, the temporal lobe has a bundle leading from it that goes across the anterior commissure. So if you do a complete anterior like a temporal lobectomy and mesial structures, there should be no need to do commissurotomy. However, That being said, in patients I've had who have failed, and I've done a complete disconnection to my eyes, and the only thing that I can see is that the anterior commissure is intact. I'll sometimes go in endoscopically and do a commissurotomy endoscopically to see, and then that's helped in some of my cases for sure. It's a minimally invasive approach, but it's one that you would do after you very carefully study your post-op um, MRI scan and make a good case for that's where the seizures seem to be coming from. Still something left either within or around anterior or temporal lobe areas, and then a commissurotomy can be done. I haven't done a posterior commissurotomy often, although I have done it. But anterior commissure is quite easily targetable and may be the source if you've left a few aspects of the temporal lobe in situ.
Jim, I remember Vilmuir's group publishing about this, and always take it to heart when I've done them because I recognize that was a source of failure.
That's right. Yeah, so it can be, and I don't do it up front, but it's something I would come back to if I have a failure, and it could be a failure after 5 or 7 years, and it's a very simple procedure to do because typically the ventricle is very expanded on that side, and you can target the commissure with navigation and the endoscope or an open approach.
Thank you, Dr. Akka. Just a question from me. Has the hemisphere that has been disconnected, has that been studied as to what happens in terms of its, is there a second brain that is pretty much muted? Is it still trying to function? Do we know what happens to that isolated hemisphere?
Well, yes, what's curious is that isolated hemisphere that you've operated on continues to have interictal epileptiform discharges. So, but those discharges are disconnected. They're not going anything. They're not achieving any function. And progressively over time, you're seeing atrophy and you're seeing shift of the brain to the side that was operated upon. And the Sylvian fissure, if you study Sylvian fissure, tilts down. So a lot of changes occur on the operative side. But in terms of the functional analysis, very little has been done to really characterize what's going on intrinsically within the operative side of the brain. But we do know that if you do EEG, don't get disturbed, that you see all this seizure activity. On MEG, you see all these MEG spikes on the affected side because it's still seizing, but you've disconnected it from talking to the other side of the brain or going anywhere in terms of seizure activity.
Thank you. Thank you so much, Dr. Akka, for that fantastic lecture and
Sure enough.
fielding those questions. Much obliged. So I will introduce, let me see, Dr. Jallo. Let me see whether I can get it. So the second lecture is going to be from Dr. George Jallo. Dr. Jallo, again, is a doyen of pediatric neurosurgery. I had the pleasure of knowing him since 2001 or even earlier. I think I started a journal called Annals of Neurosurgery, which was the first peer-reviewed journal, I would like to say, in electronic journal. And Dr. Jallo was then a fellow of Dr. Fred Epstein. He's from the school of Fred Epstein's prodigies. And he kindly sent me a manuscript on ependymomas, and that was the great start for the journal. And he has been ever since, has, like Dr. Akka, been very supportive of the listserv. So it's a real pleasure and honor to introduce Dr. Jallo. Dr. Jallo, he did his undergraduate study at William and Mary College, and I did my medical school in Aberdeen University in Scotland, and it was an old student of Aberdeen University who founded the William and Mary College in Virginia, I think, and it's the second oldest institution, as far as I know, in America after Harvard. So that's where he did his undergraduate study. Then he did his medical school in the prestigious University of Virginia. And then he did his residency at the NYU at the time of the greats of Dr. Fred Epstein, and I'm just my memory is slightly fading. The great neurosurgeon who introduced the stereotactic neurosurgery. Who was the
Pat Kelly.
chairman? Dr.
Pat
Kelly.
Kelly.
Dr. Pat Kelly. Yes, Dr. Pat Kelly, in fact, was one of the first people to have a website for neurosurgery. So it was that's going back to 1992. And then Dr. Jallo did his fellowship with Dr. Epstein, and then worked with him in New York before moving to Johns Hopkins, initially to Baltimore, where he worked with Dr. Ben Carson, and now he is at the All Children's Johns Hopkins Hospital at St. Petersburg in Florida, where he was the chair of the department. Now he's the vice dean of the hospital, as well as chair at the Institute for Brain Protection Sciences. Dr. Jallo has written several books which are staple of pediatric neurosurgery. And if I may say so, Dr. Jallo, I connected Dr. Jallo to a publisher back in 2003 or something, and Dr. Jallo really signed me a lovely. He signed the book saying that thank you, Naren, for having connected me. So, Dr. Jallo, it's a real honor and pleasure, and looking forward to your lecture on tumor surgery associated with epilepsy. I'll pause my. Thank you.
Thank you, Naren. It's a pleasure to be here this morning, this afternoon, and to follow Jim's talk on hemispherectomy, really on brain tumors and epilepsy, when really the tumor removal is not enough. I'm going to share it. Do you want to just tell me, are you able to see the slides, or should I go to the other mode?
I think it's probably better with the other mode, Dr.
Okay.
Jallo.
I will stay here, and then let me just make this a little larger. Okay. How's that?
Fine.
Good.
Yeah,
that's good, George. Yeah.
Okay, thank you. Hopefully we'll figure that bug out for Sadi and I. Sadi, you can figure it out afterwards. So really, I think the question here, and we're just thinking about it, is, you've got the child with the brain tumor, and you have a child with seizures, and there are many things. I think a lot of times the initial presentation of a brain tumor is a single seizure, and that's a first-time seizure. I think this is not what the talk is going to be about, because we all recognize that a brain tumor, first-time seizure, the goal is maximal safe resection of that tumor, oncological treatment, not really planning on epilepsy surgery. What we're going to talk about is really the other types of children that may have long-standing epilepsy for many years, and eventually there's the diagnosis of brain tumor. There's a small population of children that have a brain tumor that is removed and had seizures to start, but the seizures have never stopped, and really the epilepsies continuing to evolve from their initial presentation. And then there's another subgroup of children that have had surgery for their oncological surgery, and their seizures have stopped, and a lot of these may be off medications. However, after some period of time, there is the new development of epilepsy. It could be while they're on, adjuvant therapy, or it could even be after their adjuvant, whether it be radiation and or chemotherapy. And then, in that subset, is there biggest concern is there tumor recurrence, progression, or is this epilepsy that may not be associated with a lesion? So I think it's really as I was talking about, the first-time seizures with the diagnosis of brain tumor, the standard oncological resection controls really the events. The long history of seizures and the delayed diagnosis, typically it's going to be a low-grade tumor, the leads that we will talk about, and then the child that had a brain tumor went through treatment and then later on developed seizures. So I think, when we talk about seizures as a presenting symptom of a brain tumor, it occurs in about 10 to 30% of children. So almost, anywhere from 1 in 10 to 3 of 10 children, the initial presentation of their brain tumor may be a one-time seizure or an initial seizure. And as what you would expect, 90% of these are going to be supratentorial and will be spread throughout the supratentorial lobes. The majority, a third, are going to be in the temporal location. Maybe a quarter will be frontal, about 15-16% parietal, and least common is the occipital. And these are typically seen in your slow-growing tumors, your low-grade tumors, DNAT, ganglioglioma. And what we do know is that a gross total resection should control the seizures in up to 80% of these presenting children. And then some children may have their seizures worsen despite anti-seizure medications after they've been treated because of tumor progression. And really the clinical challenge is balancing oncological treatment with epilepsy management, and that really the anti-seizure medications chosen must be careful given the drug-to-drug interaction between therapy and tumor. This is just an illustrative case that I want to share. This was really a recurrent oligodendroglioma glioma that was continuing to have seizures despite changes in their anti-seizure medications. And you can see the different seizure medications and the MRI scans. And you can see there's this, again, a small residual that was maintained given the proximity to the central sulcus and the motor cortex. But over time, even on treatment, you can see that with the tumor growing, the number of seizures was increasing despite multiple medications. And the question comes, what are the next steps for this, given the location within the epileptic cortex? So the other, question is there a connection between the brain tumor and eleptogenesis? And clearly, we understand that, the electrophysiological or hyperexcitability of the neuron activity is really detected at discrete sites at the brain tumor interface, or really at the infiltrating margins of that tumor. And we do know that glutamate, which is involved in eleptogenesis, is also very involved with brain tumors or glioma growth. And that really, there's the direct cell-to-cell connection between the glioma cells and the tumor cells, peritumoral, which leads to hyperexcitability of those adjacent neurons that may portend to refractory seizures. Looking at these low-grade epilepsy-associated tumors, the leads, they commonly present with seizures in childhood, and that the seizure freedom is similar, is that the extent of resection portends to a better seizure freedom rate, up to angle 1 and 85 to 90%, and that a lesionectomy alone can risk persistent seizures, especially when the peritumoral network is part of the seizure network. And looking at certain subtypes, the DNATs, where they present with seizures and up to the majority of them, you can get excellent control with just the oncological resection of that tumor. One may consider stereo EEG or ECOG to better define the peritumoral seizure zone. However, I think the extent a supramaximal resection will be helpful for those. The pleomorphic xanthocytomas, their seizure freedom rate is a little less at 78% after gross cell resection. And then your other low-grade tumors, angiocentric tumors, the plenties, typically are cortically based and very eleptogenic, and that complete resection is going to yield the best results. And I think the practical points here is that if the MRI, the EEG, and the clinical semiology is concordant, and with a short duration of epilepsy, that a lesionectomy with a gross total resection should suffice and yield a angle one results with seizure freedom at about 70 to 90%. And really using invasive monitoring, especially when the discordant studies, if there's eloquent cortex involved, or if there's a longstanding epilepsy that may suggest a broader network. So I think, looking at the timing and some of the recommendations, there have been several papers you can see there that looked at this, and in a single meta-analysis of over 800 children, a pre-op seizure duration as well as a gross total resection were independent predictors of the outcome of seizure freedom, and that the early resection of these tumors yielded better seizure freedom than if in children that had a prolonged history or a longer duration of seizures associated with these tumors. And that we do know that neurocognition is time sensitive, that really, the longer pre-op duration of seizures or refractory epilepsy, the more likelihood that these children will have a lower IQ and a psychosocial outcome. Looking at these late onset post-terminal epilepsy, this is children that may develop seizures or refractory seizures 1 to 5 years following treatment, surgery and adjuvant therapy for their treatment. And some of the risk factors is really the radiation therapy at a young age, surgical scarring or development of scar tissue, gliosis, and then if there's the development of long-term networks. And the workup really has to be comprehensive with the MRI, tractography, a video EEG, PET, SPECT scans, and considering a MEG scan and neuropsych. Essentially, you're doing formal epilepsy workup for these children that have had a brain tumor. And in some cases, a tailored stereo EEG, and may consider some neuromodulation that Sadi's going to talk about for some of these non-resectable or diffuse networks. And I think really, just to summarize, the extent of resection is probably the strongest predictor of seizure control, and you're really trying to remove the tumor plus some of the eleptogenic cortex when feasibly safe, and that the earlier intervention to prevent secondary eleptogenesis and cognitive deterioration in using select monitoring. So, looking at that meta-analysis that came out of the Texas Children's Group, and what they found was that in their meta-analysis of 26 studies, open surgeries, no lids, that seizure freedom in children was close to 80%, and that the complete resection increased the likelihood of a seizure-free outcome in comparison to a biopsy or subtotal. And in patients that gross totals achieved, not only had improved tumor control, but also had significantly improved seizure control. However, the limitations of this study were there were many different histologies, locations, as well as many different surgical approaches for these operations. However, I think from this study, the better resection gives better results, but does not promise a perfect result. And sometimes if one performs a lesionectomy, why does it fail? And you can see some of the references there. Although the extent of resection is important, sometimes there's other related factors such as the location, the histological diagnosis, as well as the burden of epilepsy, the duration, as well as the tumor grade. Is it failing because there's the peritumoral cortex has become eleptogenic? Is there a risk of dual pathologies, a brain tumor, as well as some cortical dysplasia or some malformative process? And then are there secondary eleptogenic sites that may be remote from the tumor itself, and that if the MRI, the MEG, or the EEG or discordant, or is there a multilobal network? I think, looking at this multi-institutional study that looked at extratemporal low-grade tumors and seizures, and what they found in their multi-center study was that the supramaximal resection did not seem to offer a statistically significant benefit, suggesting that the perial tumor is not enough of criteria for defining, and that taking more around is not enough, and that maybe we should be studying these children in an epilepsy prior to doing the tumor resection. So, studying these children it's really ECOG, electrocorticography, is the mainstay, and that should this be done in all children that present with a brain tumor and a seizure, and should this ECOG be used as a guiding tool for the resection of the tumor, especially when there's a diffuse tumor or a hemispheric tumor, as in this case here. You can see there's multifocal tumors, diffuse, but using ECOG helps identify the location and the extent of the resection, so it be able to achieve both an oncological as well as an epileptogenic resection to better control these seizures. So, as epilepsy surgery and brain tumors, I think the goal is to have no residual tumor and to be seizure-free and have no new neurological deficit. That's the win-win. You can have no residual tumor and still remain with seizures, and one may have a deficit or no deficit. I think really what we don't want to see is a residual tumor and continuing to have seizures and with a new deficit that was not present, as evident in that monster there. So when I look at this, here's the algorithm that I will choose. Looking at the child with the brain tumor and seizures, is it the first time seizure? Is it just diagnosed in a child that's had active epilepsy, or is this late onset seizures where previously there was no seizures or they were on seizure medications and controlled? And looking at this, if one is a first time seizure, consider the advanced ancillary tests, functional mapping, and then proceed with craniotomy for tumor resection with or without ECOG, or using some of the newer techniques such as laser ablation. For the late onset seizures, after resection and treatment, really these are the ones that need to have an evaluation for their epilepsy with the phase 1 in the epilepsy monitoring unit, and may proceed on to phase 2 evaluations with grids or stereo EEGs before proceeding to a resection or some new modalities to control their seizures. For those that are diagnosed with a long-standing epilepsy and tumors just discovered, really, if the epilepsy is not controlled, should probably more likely proceed with a phase 1 evaluation. Whereas if the epilepsy is controlled, depending upon the duration of symptoms, one can consider, the adjuvant therapies and going on with the resection versus longer duration, and what type of tumor. Is it discrete, extensive, location before proceeding with a resection versus monitoring for that. So I think, the question is ancillary tests. When I think of the key is where's the location of the tumor? Is it near eloquent, motor, language, visual? Is it close to a potentially epileptogenic structure such as mesial temporal lobe? And if the tumor is there for a while, how well controlled is their epilepsy or their seizures? And types of ancillary tests one can consider an awake craniotomy. However, this is really dependent upon that age, location of the tumor, and the development and cooperation. Neuromonitoring is really helpful, although less reliable in the younger children. Transmagnetic stimulation, MEG, great for mapping, and both for seizure localization as well as for mapping the eloquent areas. And we heard a little about tractography. functional MRI and some newer techniques really of a resting state functional MRI, which may be helpful in the younger children. So we're really trying to win both battles, control the epilepsy and the brain tumor. And then, if phase 2 is an important step, should one consider stereotype EEGs versus grid, or a combination of the two? And really, I think it's the integration that is critical in mapping. So, here's a case of this left posterior temporal tumor, and one must consider the location as well as the proximity to Wernicke's area, and where are the corticospinal tracts in relation to this. And again, with the adjuvant therapies that we have, adjuvant modalities that we have, considered diffusion tensor, TMS, functional, and even an awake craniotomy. And after resection, one can appreciate that there was really, with all that technique, there was no language deficit, no motor deficit, and really no seizures at the short-term follow-up. And this was, really looking at comparing the two modalities, stereo EEG and subdural grids. I trained in era subdural grids. I must admit, since my relocation here to Florida in 10 years, I think I've only placed 1 or 2 subdural grids, and essentially have moved over to stereo EEG. And I think you can see that, I think the subdural grids do provide some information that may not be feasible with the stereo EEGs, but they really have a higher risk of CSF leak, infection, as well as complications. And I think, looking at the advantages of the subdural, it does allow for, a broader surface area as well as mapping. However, really the subdural grids can't access the deep structures such as, near the mesial temporal lobe or the insula. So I think, the decision flow, looking for the controversies, where stereo EEG, the high frequency oscillations, language mapping, the location, as well as the trajectories near critical structures, is very critical in the decision making. And I think, the future may be connectomics to help map these networks, prospective validations, and or hybrid procedures with lit and neuromodulation. I'm going to just go to an illustrative case. This was a 14-year-old boy that was diagnosed with this large left temporal mass. And really, he had a long history of occasional headaches and a new seizure that triggered the MRI. On examination, there's really no deficits, no motor deficit, and no language deficit. And you can see on the both the T2 as well as the post-contrast MR, there are some vessels within this tumor that is predominantly located in the left temporal lobe, extending probably about 9 centimeters back from the temporal tip. And I think the key here in terms of the workup is, evaluating the child in the epilepsy monitoring unit, getting the complete studies, the MEG neuropsych evaluation, and the TMS, and identifying that where the expressive language area is, and clearly that it was in the left hemisphere, in very close proximity to the margins of the superior and posterior margin of the tumor, and that the middle temporal gyrus had also a role for his receptive language in this area. So, looking at this, did the surgery with the technology in the intraoperative MRI, and did ECOG intraoperatively before and after, to ensure that we were able to ablate or be able to remove any of the peritumoral networks. On histology, it was as expected, a glial tumor with a TP53 mutation and elevated. So really, it was a higher grade tumor, and he was then treated with focal proton, and then started on a clinical trial, and he's completed almost half a year of therapy. And really, I think the last MR shows that there's been no evidence of tumor recurrence or leptomeningeal disease, and he's had no seizures since that approach. Here's a second case as I begin to close. Another young boy that had a history of a low-grade tumor, probably a DNAT elsewhere, had a resection about 5.5 years ago, and was already on chemotherapy and had failed 2 targeted therapies, and the tumors continuing to grow. It was continuing to have longstanding epilepsy, and the question was the epilepsy coming from the tumor, or were there other areas where the epilepsy was originating from? And you can see the MRI here on the axial MR. I'll try to speed it up. That, again, there was a multifocal tumor both in the midline there, in the interfornical area, as well as in the frontal and a little in the temporal lobe as well. Here it is on the coronal images. You can see the subfrontal location of the tumor extending across the sylvian fissure into the temporal lobe. However, I would say the mesial temporal structures appear to be intact, although the tumor was abutting them. This was a case that we decided to perform stereo EEG and place depth electrodes and try to map the exact location of where these seizures were coming from. And you can see on the CT scan, all the electrodes that were placed in this, and it was amounting to about 9 or 10 electrodes that were placed. And then we decided to stage the resection, first going after where the seizures appeared to be emanating from, which was the temporal lobe. That was not really associated with the tumors. So you can see the tumoral resection there, and then following the second stage of using a midline approach and removing the tumor, that this child is now seizure-free and has controlled their tumors 6 months following surgery. So I think I'm just going to close, is that really intractable epilepsy is a progressive disease and has destructive effects on the growing brain, and really should consider surgical options early, whether it be early in the course of the treatment, and offer that in addition to the tumor resection. And the best approach is really a multidisciplinary approach. Thank you for allowing me to share my thoughts on brain tumors and epilepsy.
Thank you very much, Dr. Jallo, for that comprehensive talk of a very complicated area that always is a challenge to tease out. So if I may ask Dr. Sadi Gatan, first of all, for your thoughts on the talk and your questions for Dr. Jallo. Thank you.
George, great job. Fantastic talk. And as the audience will hear, this was really the genesis of how I got into neurosurgery, full stop, was in the study of these exact scenarios. And it's amazing how far the field has come. You hit the nail on the head that stereo EEG can be absolutely critical in better delineating for us what really is at stake here. Is it just the tumor? No, not usually in these low-grade cases and the more chronic cases. We've got to find what the peritumoral seizure network entails, and it is truly a multidisciplinary approach that's necessary. I would probably emphasize that all of the testing that we are doing here in the United States is not necessarily as critical as the semiology that the patient presents with, the MR findings, the video EEG. Sorry about those balloons. And and if we're capable of doing it, invasive monitoring with corticography. So I second the emphasis that these are problems that are often at times distant from the primary tumor that need to be addressed and addressed successfully and safely.
No, thank you. Sadia, I wholeheartedly agree. I mean, I think, when I was in training, I thought, you take out, tumor seizures, take out tumors, seizures stop. And I think it's come a long way, and we have a better understanding that not necessarily, right? And with the technological advances, you may have to shift your practice and stage it, right, with stereo EEG and other adjuvant modalities to be able to achieve the best outcome for that child, in addition to oncology as well as epilepsy.
Thank you, Dr. Gatan. Dr. Ratka, your thoughts on the talk, on the lecture, and your questions for Dr. Jallo. Thank you, sir.
Yeah, thanks, Naren. And George, great talk. Thanks. And your last case that you presented, that was fabulous. What an outcome, and what a really tricky lesion that you were able to map out and help this child with seizure control. So yeah, that's kind of state of the art, as Sadi also mentioned. I had just two quick questions. One is, what's the youngest age that you've done awake craniotomy, and is that a technique that around the world, low middle income countries, they can use as a monitor if they don't have all the functional mapping and everything else that we have access to? Is that something that they might be able to do in their environments? And then secondly, have you seen Rolandic, meaning either primary motor strip or somatosensory cortex lesions, like arising from like the precentral gyrus? I never thought I saw one of those until recently, and then it was clearly within the primary motor cortex, and it was low-grade glioma. I had a BRAF mutation. We just biopsied. We couldn't resect it. And kind of a segue into Sadi's talk coming is we ended up doing sort of neuromodulation for a case like that because we couldn't take the lesion out. Placed on targeted therapy for the low-grade glioma, but VNS was tried, that didn't work, and then we moved to RNS in the face of a tumor that was there, and it actually worked, but we're still monitoring the tumor. But yeah, maybe some comments along those lines, awake craniotomy, and then Rolandic tumors that are low grade. What do we do about those?
Excellent questions, Jim, and thank you. For the awake craniotomies in the youngest, for me, I mean, I have a limited experience with the awake craniotomies in children, but the youngest successful one that I felt comfortable doing was maybe 10, 11. I know others have gone younger, and I think it's really dependent upon the maturity of the child. But I hesitate to do an awake craniotomy on someone younger than 12, honestly. I think it's stressful for the team, stressful for the surgeon, and stressful for the child and the family. But others may have different experience. On those Rolandic lesions, tumors, and seizures, it's funny. I'm so glad you brought it up. I've had two kids with it that had tumors in primary motor and seizures, refractory seizures. One that I'd say I did about 6 or 7 years ago here in Florida, and we went in, had ECOG, had motor, phase reversals, motor stimulation, everything, and we were only able to achieve an excisional biopsy because of the proximity to the central sulcus. We controlled the seizures for a little bit. I think it was more from the swelling than anything else, but then they came back with vengeance. And that we didn't know what to do, and she continued to fail medications. But after a discussion with the parents, they're willing to accept the deficit. And I did go in a second time, remove it, and she woke up. It was midline, so she did wake up with a foot drop, and she did recover. Is she fully functional? She's independent, walking with a slight hemiparesis. So, I think, it's a discussion with the family, and she's seizure free, no medications now, which is great. I mean, that's what they wanted. they're willing to accept that. The second child that I have, and this was more, I think, this year, and Sadi, thank you for the work that you've done. Same thing, we did, essentially it was an excisional biopsy, seizure stopped, but then returned with vengeance. And we did put an RNS in that child. And I will say, it's been 3 months, 4 months, and the seizures are controlled. And we're just going to watch it. So I don't know, again, I think we're able to offer more for these families. And whereas previously I offered the resection, family accepted the neurological deficit, this family wasn't willing to do it. So we went with RNS, and it's been successful. There's been better control of the seizures. Is she
great,
seizure free? No, but we'll see.
Yeah, thanks, George. That's great.
Thank you very much, Dr. Jallo. There's in terms of the question, there's one from the great Dr. Arthur Kahuna, who's saying it's a great lectures, and whether it will be available. The recordings will be available. The recordings will be available in YouTube within 15 minutes of finishing the lectures, but then I will also edit it and individually publish it in YouTube as well as Vimeo and another text image stream. So the nice thing about Vimeo and the text image streams is that if there's no adverts to interrupt, so you can concentrate on the lectures, but YouTube is always a place for posterity. Then there's another question, Dr. Jallo, it's more about training. We will come to that at the very end about training in epilepsy surgery, pediatric epilepsy surgery, and then once you become a consultant, the mentor relationship. But thank you very much for that excellent lecture, Dr. Jallo. So I will just get my presentation to introduce Dr. Gatan. Let me see.
Naren, how's that coming across on the screen?
Sadi, is it okay if I put my slide of yourself first, and then?
Of course.
Okay? Thanks. So it's an unbelievable pleasure to introduce Dr. Gatan. If I may ask, call him Sadi because I knew him as Sadi. We met at the ISBN in Toronto last year, but this is meeting after 30 years, and Sadi hasn't changed. I have certainly changed, but so I managed to find it was Sadi. Sadi trained did his residency in Seattle, and once again I was a medical student in Aberdeen, and then I did research in Atkinson Mole in St. George's. Both of them had links with Seattle, and I went to Seattle to do my elective, and Dr. Wynn did all his best to get me to spend 1 month as an extern and 1 month in research. But you have to understand, Seattle in the 1990s, it was the mecca of neurosurgery. You had Dr. Wynn, you had Dr. Ojiman, Dr. Mayberg, Dr. Sean Grady, Dr. Newell. These were all legendary neurosurgeons all in one place. But Sadi was a resident, but he was a golden resident in that department. He was destined for greatness, which he has achieved. But the amazing thing about Sadi is that anyone who knows Sadi will know that he has the same ability like the Clinton or Mamdani to relate to people. My name is long and it is difficult, but he insisted that he's going to exactly pronounce this. And you have to understand, I was just a medical student, and he does not know who I was then, but he was quite a senior resident by then. But he took time to figure my name out. Not only that, then he asked me what's the hardest name from Sri Lanka, and I told him the classmate's name, which was 16 letters long, and he remembered it, and he remembered it 30 years later. So Sadi is one of those people who actually genuinely loves people, and it was a privilege being his extern. So Sadi then did his research fellowship in Great Ormond Street, pediatric resident fellowship in Seattle. Once again, they were great pediatric neurosurgeons at the time. Then he went to New York, and then he has a huge practice and pediatrics as well as functional. And this functional neurosurgery in epilepsy is a big hot topic in UK, as you would have seen that the largest number of delegates were from UK for this meeting. And I have to say to Saadi, I think I did send an email to Saadi because I trained in Southampton, and we had Dr. Jason Bryce, who did the first randomized control trial for epilepsy surgery back in, I think, 1984. So I'm proud of that. So I'm really looking forward to your lecture marrying both this pediatrics and functional neurosurgery, which is greatly awaited by the delegates. Thank you, Saadi.
Well, thank you, Naren. I hope this is coming across readable, and I will start by first thanking you for the honor of being able to present to this outstanding group and an international group, which is of critical importance, as well as alongside these two names that are synonymous with greatness in pediatric neurosurgery, Rudka and Jallo. And I'll start with my disclosures, which mainly revolve around the credits, to emphasize a point that George made just now, that the most meaningful way to get the job done in epilepsy is from a team approach. And without my epilepsy neurologists, who do the vast majority of the heavy lifting, I would be nowhere. And my neuropsych team, apologize. The neuropsychologists are a critical and integral part of my work, not to mention my partners in radiology, neurosurgery, neuropathology. And then a point that I learned early on in Seattle was to try to combine our clinical work with our neuroscience work, because the brain is our own living laboratory in which we can safely and ethically learn. I also became a believer that we must partner with industry in our work, and you'll see some relevance to that in my talk. And then ultimately, the patients and their advocates are the ones who approach us with the great suffering, but also the greatest courage, and we must match their courage with that of our own to continue to expand this field. I got my start ironically with George's talk in this very arena with some big names in retrospect now. Mitch Berger and George Ogeman were two of my mentors in Seattle. And this was as a first-year medical student, realizing the satisfaction of getting it right when children presented with brain tumors and epilepsy. And I must give a shout out and great credit. And I didn't even know Naren was going to emphasize the history of the Department of Neurosurgery in Seattle. But here is a shout out to my mentor, Dr. Wynn, Drs. Ogeman, Berger, who was my first inspiration to go into neurosurgery. And then ultimately Ted Roberts, the great innovator there in the center of that right-sided picture, who really was just a consummate gentleman, human being, well-rounded person, but innovator in neurosurgery at the same time. And you'll see how mentorship comes to play a critical role in the work that we have gone on to be able to do in pediatric epilepsy. We're all familiar with the suffering of a young baby with a large cortical dysplasia, refractory seizures 20 to 30 a day, and the old school method of exposure, grid placement, invasive monitoring that George referenced already, and the pitfalls associated with it. It's not a minimally invasive approach, but ultimately the very gratifying outcomes of a child being able to walk out the door without a deficit and 20 years later, now seizure free. Yet we also know that there's good class 1 evidence for this provided by our colleagues in India. And this is some of the work that I've been able to do overseas on a yearly basis now in Mongolia, when the conditions are right, with focal cortical lesions, with epilepsies related to scarring. And here we are conducting an awake operation because we don't have access to grids or other kinds of invasive monitoring. And my neuropsychologist there at the patient's side, we're able to achieve great outcomes with the standard approaches. Here's 5-year-old Rasmussen's that had a great recovery within a few months, to emphasize and understand Jim had talked about in his talk. So indeed, we have the ability to get great outcomes with classic approaches, but in pediatrics, we're also fighting a major problem in epilepsy, full stop, which is that the number of people with refractory seizures who actually get care is a drop in the bucket. And in countries that are under-resourced, that don't have access to the same anti-seizure medications that we do, this problem is amplified. And in pediatric neurosurgery, we're not always greeted by the focal cortical dysplasia in the non-dominant temporal lobe, or the focal lesion that lends itself to a focal resection or even a regional resection. We have these very difficult problems like Lennox-Gastaut or multifocal onsets for the seizures, other more severe migrational disorders that have prohibited patients with refractory epilepsy from being considered surgical candidates. Even tuberous sclerosis, where it looks like you have a hot target that you can go after as a tuber, all of us know how vexing some of these patients their seizure disorders can be, with recurrence of their seizures in this sort of mutable way. It looks like everything was coming from that focal tuber in the right temporal lobe, and then a year later it's coming from the left temporal lobe now. So we have to find ways of taking care of these patients before their epileptic encephalopathies get the better of them in childhood, emphasizing some of the patients that Jim already spoke about. And during my training in the 90s, this was the modality that we were able to apply in the late 90s to kids. And it really became, to me, what was the starting point for something that is much more acceptable to a parent or to a referring neurologist, something that's modulatory, that's less invasive. In this case, the fear of brain surgery for those parents is obviated by going to their neck and their chest. And yet, even with these small devices that can be accommodated in young children, we know that only a third of them experience a 50% reduction in their seizures, albeit meaningful results, not good enough. We go back to the historical work of this courageous professor in Mexico City, applying centromedian targeting in the thalamus for the treatment of epilepsies as far back as the 80s. And then Dr. Koop's application of deep brain stimulation in children really was the first recognition that a neuromodulatory approach, albeit in his case it was for dystonia, could be safely applied to kids. This is somewhat ironic and troubling that we reach children last with some of these technologies that we know are safe, that we know are modulatory rather than destructive, and we're not burning bridges by using them. Yet there's such a limited history of targeting the deep brain in children. my own personal story with this revolved around failure and the inability to control epilepsy in one of the two children in this case report that Jim, as editor-in-chief at the Journal of Pediatric Neurosurgery, graciously accepted for publication. But it represented the first two kids that were treated with responsive neurostimulation, and one of them was by applying electrodes in the deep brain, in the anterior nucleus of the thalamus, completely without recognition of what Professor Velasco had done in Mexico City, but rather what was following a trend going on with the stimulation of the anterior nucleus of the thalamus in epilepsy, the Sante trial for the treatment of complex partial seizures, they were known in those days, otherwise known as focal impaired aware seizures. And we had success with this, albeit limited in one of the two patients. The other one was that application that George and Jim talked about, where we were simulating the focal motor area. We had good success. The other patient was a kid with Lennox-Gastaut, where it was better than any of the prior resections, disconnections that he had undergone. We studied early on the safety of this to emphasize how safe responsive neurostimulation, whether it was on the cortical surface or in the deep brain, would be in children. And we had acceptable complication rates with infection, an emphasis in responsive neurostimulation about how to conduct the craniectomy and place the device in the head in a way that it didn't erode through the scalp. So there was an emphasis here on proving safety. But then we had to do better with those patients who were failing our standard approaches. And for example, in this case, we studied our kids who had autism, that we applied that grid and strip model to the subdural electrodes, where we're trying to figure out if there is a regional or a focal onset. And we found that in the non-lesional cases, there was a huge number that failed miserably, and we had to do better. And I know that all of you are aware of the suffering that these families that have the comorbidity of autism and epilepsy go through. We had to do better, and we came across this young man who suffered from Lennox-Gastaut epilepsy and seizures, and published an early experience with targeting the centromedian nucleus to relieve him of his epilepsy, along with another patient with a similar history, and also ameliorate many of the severe aspects of the patient's autism. So why would we choose thalamic targeting? In these cases, we should have listened to the early experience of Velasco, but in this case, we're looking at treating a network rather than looking at epilepsy as a focal disorder. And we also must reject the notion that in all cases, epilepsy has to be cut out, disconnected, or in the modern application, laser ablated. The responsive neurostimulator that we're using is out of sight. It's under the hairline. In deep brain stimulation, it's in the chest wall, which is just fine for most patients and some children. In terms of what we get out of the application of a modulatory approach, we learn about the patient's epilepsy in a way that we would not with a single disconnective or ablative treatment. And in the case of responsive neurostimulation, which much of this work involves, we are both learning from our recordings, and we're also carefully treating a developing brain so as not to apply tonic stimulation to it in a way that may have developmental, social, and psychological consequences to the patient. It's resulted in a real shift in how our center approaches epilepsy in using the thalamus, deep brain, as a target in many of these cases. The technique is quite simple, to be honest with you. To echo what I said with regard to the team, the neurologists do all the heavy lifting here. Of course, we have to place this correctly and with meticulous attention to detail. We use in our center for these sorts of neuromodulatory approaches, Alexel frame base for fixation. We use robotic navigation, which is just behind the frame base that you see here. We really elevate the patient to be able to have access to both sides through a curved incision. On the right, we place both the tray in which the responsive neurostimulator sits. In the case of deep brain stimulation, fear not, I will show you the technique there. But in this case, we're using a stimulator that's implanted in the skull, and we have to allow it adequate room. But ironically, the most important aspect of this technique is making sure there's no mass effect on the skin. The scalp and the skin of a child, which is thin and has limited vascularity, can not tolerate any sort of mass effect against it, whereas ironically, the dura and the brain can with time. The placement of the two electrodes is incorporated into this incision on the right, and then there's a smaller incision on the left for both of the deep brain electrodes. In the case of the majority of our implants, we're targeting this tiny centromedian nucleus, which is just in front of and medial to the pulvinar nucleus, which is a much bigger and easier target to hit. We're using a technique that is not based on ACPC lines, but rather direct targeting with F-Gator or MP-RAGE imaging. And we've had good success in using either frame-based, clear point, or robotic navigation. I would not recommend using freehand, certainly, and I also don't feel that frame-less navigation affords us adequate targeting accuracy, because the nucleus here that we're targeting is on the order of 6 millimeters in its greatest diameter, and to have a 2 or 3 millimeter error rate with frameless navigation is unacceptable here. We typically build a model for the target that we're going after, and again, use direct targeting, as I just said. And our work has been greatly influenced by, similar to what George was talking about, the evolution toward stereo EEG experience. It's on a simple level, very easy to reassure parents and neurologists that the safety of this procedure involves a risk of 0.03% per electrode when we're implanting something with robotic navigation, and probably even a little less with frame-based navigation. So if you think about 7,000 EEG leads in a center, or 20,000 published by the Milan group from multiple different centers, and that calculated 0.03% risk of a hemorrhage or a complication, it's pretty easy to then say that placing 2 deep brain stimulator leads in the thalamus is quite safe, certainly much safer than the patient's refractory epilepsy. We've had a big experience here in responsive neurostimulation, but we also have, with listening to the needs of our neurologists and their recommendations, DBS, classic DBS experience. And so far, we've established DBS neuromodulatory approaches in 57 kids in our center. And the classic guidelines for thalamic targeting are the LGS and generalized frontoparietal and temporal neocortical networks, we go to the central median nucleus, the ANT, anterior nucleus of the thalamus for limbic networks, and pulvinar for or posterior quadrantic epilepsies, as well as generalized epilepsies. But none of these are based in scientific analysis quite yet. We're getting there, but we still have a ways to go. As I said, we use this paper from Aaron Warren that talks about direct targeting, particularly in children, and we're aiming for a sweet spot at the anterior border of the central median nucleus when we do it. Here's more about the technique. We can use this parietal incision on the left for a pulvinar central median target. We use a small incision on the right for the central median, classic central median targeting. And as you can see, this is a little further off the midline than you would for a classic DBS approach to dystonia or other movement disorders. The NeuroPace device, the responsive neurostimulator, of course, is put in the skull. And as I emphasized, it's critical not to have anything but a passing wire running under the incision when possible, to make sure that this device is flush with the skull surface and that there's no protuberance affecting the overlying scalp. And there's meticulous attention to detail. As far as stabilization of the deep brain electrodes, we use a bent dog bone that we make ourselves here in the OR and place a little silastic sheath over it to protect the electrode and make certain that that's far enough away from your entry point to ensure that the electrode doesn't get kinked and broken with time. A couple of other points here about the technique are to ensure that you measure your distance to target from the outer table of the skull using indelible ink. Fancy that the Russians used a pencil in space while the Americans spent lots of money trying to find a pen that would work in space. The analogy here is, in order to get that target just right, use indelible ink, because the regular ink you use gets washed away and you can lose sight of your distance to target measurement. And of course, with a 6 millimeter target of the central median nucleus, you cannot be off by a millimeter or two, even in that case. As far as the DBS applications, the little children are the ones where we approach with more trepidation, because the devices are not as small as that VNS device that I showed you in the earlier slides. This device that I'm using in the case of this 5-year-old is the Abbott DBS device, the Liberta, and Jim, of course, knows about this work because George Ibrahim in Toronto and also the folks in England have done the majority of the work here. But I favor this smaller rechargeable device in this young child. The same sort of approach in terms of placement of the DBS electrodes, the same sort of stabilizers in the dog bones, and then tunneling behind the ear. And here you see in the early aftermath of surgery, this is at the 2-week mark, to take out the stitches with anterior axillary line incision to place the actual generator. And in this very small and slender guy, this sort of technique works quite nicely. You can see the minimum of hair shaved, which is a practice that I have gotten into to emphasize the minimally invasive nature of this kind of work. And then again, these sorts of scars that don't traumatize the patients or the parents too much. We found that by mapping the network using tractography and the connectomics that George alluded to, that we're getting better results in our work. And our colleague Josue Avesiles Chacin published this just this year in Epilepsy, where he and the med student Varun Subramaniam correlated better seizure outcomes with better connectivity between the specific nucleus we're targeting and the seizure network as defined by stereo EEG. Now, that's not always possible in all of our cases, and we certainly have not been able to use it with that great a frequency just yet. But I do believe that this sort of individualized approach is going to be critical in the future, and even potentially being able to identify a white matter target where there's a confluence of signals that can be modulated will probably be the best place to put our deep brain stimulation electrode. We know from NeuroPace's work, and we also know this in the work with DBS, that sustained treatment drives better outcomes, and that measuring success in days, weeks, and months is not applicable in a neuromodulatory approach. It makes sense, of course, that if we're doing a one-time disconnection or resection, we're not going to have a similar sort of sustained chronic treatment that we get with deep brain stimulation or responsive neurostimulation. And this is one of the major problems that we have in pediatrics. We're under the clock here. We have to get it right, get these patients out of their risk for epileptic encephalopathy, and we oftentimes don't have 2 or 3 years to wait till things get better. The cohort that we have here in the 52 RNS patients and the 5 DBS patients shows similar sorts of success rates, minimal complication rates, on the order of 90% seizure control. And we're talking about people who have significant seizure burden that medication obviously could not control and vagus nerve stimulation was not able to control. We found that our thalamic targeting has mainly been centromedian, and that seizure reduction continues to get better and better over time, as we had talked about. In DBS, we've seen substantial seizure reductions in under a year in most of these cases, and we still can do better, we know. And then finally, we have some experience now in implanting bilateral stimulators in the setting of Lennox-Gastaut epilepsy using what are called cortical and thalamic leads. So thalamic cortical stimulation involving detection of seizure onsets at the cortical surface and then using the thalamus as a network regulator deep inside. We probably will get better understanding and more knowledge by using stereo EEG in the thalamus. And we've seen this in the case of focal impaired aware seizures. We know that we'll probably have more promising results with this kind of a thalamocortical detection and stimulation network. And of course, connectomics is really a hot spot in the future to go after. And yet, this is not a panacea in children. It still is a work in progress, but I would emphasize to the audience a much less invasive approach than the patient's epilepsy in and of itself, and certainly better than some of the disconnective or ablative approaches that I've used in the past that resulted in futility. I also want to just highlight an article that shows that in the pediatric world, we are sort of leading the charge to make epilepsy surgery more accessible and available. And long may this continue, because these are the patients who need it the most, in my view. Thank you for your attention.
Thank you very much, Dr. Gatan, for that fantastic lecture on DBS and also the advances that are coming up. It is amazing. Thank you very much for that fantastic lecture. Just going to come to Dr. Radka. Dr. Radka, may I please ask your comments and questions for Dr. Gatan? Thank you, sir.
Yeah, great. Thanks, Naren. And Sadi, congratulations on your presentation and for leading the way with pediatric functional neurosurgery and mapping the brain and using both VNS and RNS and now DBS to really influence the way in which our children respond to their epilepsy. So thank you for that. And we're happy to have accepted your papers in the Journal of Neurosurgery over time. Yeah, so, at our institution, every child with epilepsy is getting genetic testing. And it's not unusual for kids coming forward with non-lesional epilepsy to have a genetic disturbance that's as yet unknown as to what it does. But, a lot of the indications are that the genes that are identified do something with respect to neuronal function. And I'm really reluctant now to put those kids forward for stereo EEG because of the underlying genetic disturbance. So in those instances, we're using, of course, VNS, and we've identified a very small group of super responders to VNS, and those are kids who have early responses that are very gratifying, and they also, within the first year, have demonstrated that they can go down off their medications and so on. But we really need to find better biomarkers, not just for VNS, but I think also probably for RNS and DBS. So maybe one question is about the genetics and what you do in these instances, because I actually think neuromodulation is a great strategy for these kids with genetic disturbances. And then back to my lecture, so to the first talk today, and having a kid who has failed hemispherectomy. Have you ever done centromedian DBS, either bilateral or unilateral? Are you aware of it being used? I have a case currently where we're really grappling with what to do. It looks as though the seizures may be coming from the unaffected hemisphere. So a failure because of independent foci on the contralateral side. But yeah, just comments about that. So genetics and DBS for failed hemispherectomy.
Thanks. Those are great questions because they highlight some of the themes that I feel like I'm a Southern preacher about. That genetics should not preclude treatment. Genetics were seen as a way of saying, you're not a surgical candidate, move on. And to me, our understanding, as you said, is still lagging behind our ability to recognize how to treat. Therefore, we must use the tools that are at our disposal, and therefore a neuromodulatory approach is great. And biomarkers actually exist in responsive neurostimulation because we're getting chronic daily recordings, and we follow those over time, and we can analyze them as some of my colleagues are doing. So I'm all for a better understanding of the genetics, and if there is a possibility to intervene with gene therapy, wonderful. But until that day, we must do something to help, and VNS at a minimum. And again, I submit the safety overall with modern stereotactic technique that DBS, either the classic chest implanted device, which in the case of the small kids, you have to go small, or the RNS, are perfectly safe and acceptable ways to treat. With regard to the hemispherotomy patient, it's easy you ask about that because we had a kid that suffered from neonatal meningitis who had most of her thrombophlebitis and therefore vascular destruction of one hemisphere which we went after with a hemispherotomy, and she enjoyed a few years of seizure freedom, and then seizures recurred on the contralateral side. And now we took a very stepwise approach, which in retrospect, we should have gone straight to the CM. Her seizure pattern was an LGS pattern in the less affected hemisphere, I should say. And therefore, we worked from initially using strips with an RNS to explanting everything, doing another stereo EEG, which I don't think is necessary, and implanting her central median. And now we have a vastly better, I'm not saying it's perfect, but a vastly better level of seizure control in the hemisphere that we cannot touch with a resective or disconnective approach.
Oh, that's great. Thanks.
So it is one of my slides I didn't include is never give up. And it involves the picture of the RNS.
Yeah. Thanks, Sadi. That's great.
All right.
Thank you. Thank you, Dr. Radka. And Dr. Jallo, your comments for Dr. Gattan and your questions for Dr. Gattan. Thank you.
Thank you, Naren. Sadia, excellent presentation. I've heard you speak about this. I think you're on the forefront. And that's my question. Do you think we are, as pediatric neurosurgeons, are slow in adapting DBS in placing the CM electrodes?
I think that it's not just us. I think we are capable of doing this, and we have confidence that we can do it safely. Anybody who's implanted a stereo EEG electrode knows that they can get to the thalamus just as easily, if not easier in some of these cases, because your trajectories don't involve as many vessels. It's the buy-in from neurology that I think is always the difficult spot here. And so we must emphasize to them its relative safety, but also, as I said, they do the heavy lifting with the programming, with the analysis of the recordings. Yet that is also incentivized now in a way that it wasn't before. So there's a lot about which I'm delighted, Naren, that you've put together this international audience that we can do to spread the word.
Thank you.
Thank you very much. And there's an excellent question from Dr. Van Roost. I'll just try to get it. You might be able to see it better than me here because I just managed to. Let me see. I got it. So in Dr. Van Roost asking Dr. Dirk Van Roost, how do you address the skull growth and the relative retraction of the electrode in young pediatric DBS patients? Is the electrode intentionally placed with a more proximal contact on the target and reprogrammed to the more distal contacts as the skull grows? Thank you.
So the good news in the majority of these cases, we're getting to the kids after they're 2 years of age. I think the youngest I've done is a 3-year-old. And when you think about the percentage of skull growth toward adulthood that you get at age 2, there's very little change that takes place with respect to the target and the outer table between 2 and 16. So we also remember that nucleus that we're targeting is 6 millimeters in diameter, and therefore a 4-contact electrode, which spans about 12 millimeters, 9 to 12 millimeters, depending on the type of electrode you're using, allows you to program between those 4 and not lose the target. But I would also say that going back and replacing it 10 years later is not a prohibitively invasive problem to undertake if there is a change.
Thanks. Thank you. And thank you, Dr. Gattan. I think, is there any, if I may come to Dr. Radka, is there any other points, general points, Dr. Radka, you want to raise with the faculty or mention? Thank you.
Yeah, no, thanks, Naren. I note from who's online today that a lot of folks are from around the world in areas and in regions I had mentioned earlier that may be considered slightly underdeveloped in terms of technology availability. So I think a plea from us is that yes, you can do and you should think about doing epilepsy surgery in young children, especially those with lesions, because even though they may have recurrences, if we have residual tumor, or even if we've removed the tumor, they can still have seizures. By and large, the outcomes are best for those children with epilepsy with lesions where we've done either gross total resection or lesionectomy. And so long as you can do that safely in your institution, that's what you should definitely try to do. And then there's all the work related to temporal lobectomy, where you've got all the data, hopefully EEG in your domains, and maybe a lesion or suspicion of a lesion in the temporal lobe. Those children can be operated on very, very safely around the world with a temporal lobectomy. So there's lots that you can do in your jurisdictions, even if you may not have all the technologies that I demonstrated within hemispherectomy or that George did with the mapping and resections and Saadi did with the neuromodulation studies. There's a lot of work that we would encourage you to do in epilepsy surgery in your areas of the world. And if you ever have questions, don't hesitate to reach out to us.
Thank you. Thank you very much for that, Dr. Radka. Saadi, I know that you go to, I think, Mongolia, and you're a keen internationalist. I know from the early days. Obviously your practice is busy. You have your own things to do. But in terms of mentoring from distance, as Dr. Radka mentioned, I think the epilepsy surgery is, the number of cases with these complex cases are small. So it's always good to have mentors. And are you able to mentor any epilepsy surgeons around the world, or that's something that you will also look into? Thank you.
Well, you are. First, let me reiterate what Jim said. I don't mean to say that you need DBS or a robot to be able to help here. There's so much work that can be done to help these kids who don't have access to meds and don't have access to regular neurology follow-up. In Mongolia, that's the essence of the work we're doing. The patients are coming from the steppe with nomadic lifestyles that don't allow them to go to centers of excellence for surgery. And surgery actually becomes curative in the majority of those cases that are brought to us that we really can help. I mentor the surgeon in Mongolia through repetition and hands-on experience year after year. And now we're at the 5-year mark of his experience in doing this. He's a very talented surgeon. He claims that temporal lobectomy is harder than any basilar aneurysm he ever faced in his life. So it emphasizes it's a complex thing to teach, and therefore I'm very happy to mentor. We had a Nepali surgeon who came and spent a few months with us here in New York, and we of course have neurologists who outreach there. But it's a challenge, Naren. These are tough cases. There's no question about it. And I'm happy to mentor anybody and everybody who understands what these families and these patients are up against.
Thank you so much, Saadi. I have included the emails of the faculty in the emails that I sent out. So anyone want to contact probably can contact, but I never gave the emails, but I did include them explicitly in those emails I sent out. Dr. Jallo, I think, whether you are in developing country or developed country, epilepsy surgery for a resident to become an epilepsy surgeon, it has a learning curve and with the high expectations of family by the neurologist, looking at everything, and now the governance. How do you think that training has changed from what it was when you started epilepsy surgery and what it has come now? Thanks.
Yeah, Naren, I think that's an excellent question. And as both I think Jim and Sadia said, there is a learning curve. The more you see, the more you do, the better you will be as a surgeon doing this. There are nuances that you must understand if you're going to participate in an epilepsy operation, but it can be done regardless of where you are in the world. I think, one is, going to centers, learning, watching, learning, doing anatomy labs. And then, Jim, I think that simulation laboratory, model that you've established is second to none, especially, for some of these procedures. If you're not at a high volume center, you may not be exposed to them. But I think we've come a long way, from when I trained. When I did my residency at NYU, when you finished as a pediatric neurosurgeon, you were expected to be able to do this and do any operation in pediatric neurosurgery, and I'm not sure that's true. I mean, I think you really need to further subspecialize in epilepsy. I can tell you, Darren, I mean, I think I do everything in epilepsy. I don't do the DBSs, Sadi. I just don't do it. I haven't done them. I didn't do enough during my training to be comfortable doing them. So I asked one of my other partners to do those procedures.
Yeah. No, I hear you when you say when you come out of training, you're expected. It took 10 years of agony and stress to feel comfortable with some of these things. And there's nothing easy about it. Nothing straightforward or simple.
Thank you. Thank you very much. Dr. Radkar, do you have any last thoughts on this question? Thanks.
I don't think so, Naren. It's been a great session today. Very, very much enjoyed being with Sadi and with George, and thank you for organizing for all members who attended today. Hopefully this gave some good information for everybody about current and latest trends in epilepsy surgery. Thank you, Naren.
Thank you.
Thank you. Thank you very much, Dr. Radkar. Just housekeeping things. First of all, the distinguished faculty, I think I just remembered a couple of things to add to the bios. With Dr. Sadi Gahan spent a year in Atkinson Mole in UK training as well, so he has a international flavor, and I think he then took one of the pharmacists with him back to UK to US. So that's Dr. Gashan, and Dr. Radka. He's as you will probably know, he's honored by Canada. He got one of the honors from the Canadian government and from the Ontario government, as well as his contribution to Ukraine during this war has, for the neurosurgery, there will be long memorized, long be cherished. So thank you very much. So thank you, Dr. Radka, for that. And so in terms of the three things, I'm just going to sending them on the chat box. So there are four links. Yes. The first one is a feedback form, and in the feedback form you can give feedback about the talks as well as the organization, as well as whether you want to have a certificate of attendance. And it was one of the registrants who asked for an MCQ, and so these feedbacks are very useful. And the three speakers have given MCQ questions, which I have it at OneNote and put it on the web, and so you can go and do that MCQ to understand how much you understood. And the other thing is these lectures are fantastic resources. You can go and look at them on the YouTube now. So I have put the link there, but I will also individually edit it and publish it in YouTube and Vimeo and the text events stream platforms. So last is that if any of you want to join the listserv, you are very welcome to join the listserv. I have put the website of that at the bottom, and if you want to join, just send me your email and you are working. So first of all, I'd like to thank all the participants who have made this meeting worthwhile for the faculty. Thank you very much for joining. I know that it's not easy on a Sunday. If, it's not COVID days. We have to live normal life as well. So I was trying to find the time. So thank you very much for all of you from around the world coming. And I'm really like to thank with the bottom of my heart to the three very distinguished faculty members taking time out on a Sunday, and all three of them from North America in the early morning. So thank you very much, Dr. Adka. Is very grateful. Dr. Jalo, thank you so much again for your support, and Dr. Gatan, thank you so much again for everything, for these lectures and the quizzes and everything. So I'm wishing you all a great morning and day for those in the North America, and for those in this part of the world, a good evening, and see you in the next meeting. Thank you so much. Bye for now.